Thank you very much. I am going to talk to you about some stuff that we've been doing for quite a long time. In fact, this was sent to me by Sherrie Kaplan. Apparently, I gave a very similar talk at AARP in 1991. So, in terms of progress, I cannot promise anything exciting about progress, but at least I'm going to give you a fill-in about where we're going. Patienthood's this notion that, you know, we become patients as opposed to we stay in that role. We become patients, we leave patienthood, we become patients, we leave patienthood. So what are we asking patients to do now? Well, we ask them to choose and change health plans, choose and change providers, give informed, quotes, informed consent, participate in some treatment decisions, although going up, that's rare still, follow through on treatment plans, pay the bill increasingly, and interpret health information, particularly performance data. So what help do we give people being patients? Well, not very much. I mean, you can see the kind of, sort of in order the things we do. In open enrollment, I don't know if you all have had this experience, but at open enrollment time, I get the data on the health plans options available to me in font the size that it takes me, even with a very heavy magnifying glass to read. Physician directories, even these give you increasing information about quality, but they mostly give you information you don't know how to interpret. Appointment reminders, blah, blah, blah. And we really don't give them very systematic help in making any of these. Systematic is the underscore, because we've got great examples of each of these individually. So currently, there's no systematic training preparation for being a patient in the US right now. There's no systematic training. It shouldn't surprise us then that the average patient asks fewer than 4, you could argue 5, lexical questions in a 15-minute office visit, including, can you validate my parking, questions like that. And most patients don't participate effectively in treatment decisions, and although we have really good patient education programs in some areas, those improve knowledge, but they tend not to be associated with important health outcomes. I'm going to get in trouble for that later. But why haven't we done this yet? Well, there are some prevailing myths. One is that patients are too poorly educated. They're not well enough prepared to participate effectively in care. Another one, as we just heard, is patients don't want to participate in care. Some people really do want to be passive recipients of their care. If you increase patient participation in care, you'll lengthen the office visit untenably. And if you encourage patients to participate, they'll become difficult patients. And patient training, and I'll come back to sort of challenging these myths in a second, patient training is kind of, to participate in care is too new. So why do it? Well, this is an article that we published about 2 years ago in Medical Care that in fact shows when the physician effect is on the vertical axis, when the physician effect begins to stop and the patient effect takes off. And that's right about where exactly the targets for physician control, this is blood glucose control, hemoglobin A1C values, this is just about where the definition of out of control begins. So if you want to reduce patienthood down to sort of reduce patients' values on this down to the target, you have to get patients involved. There's that patient effect takes off right at the definition of out of control. And the same thing is true, although it's a little harder to see for LDL. So to address the question of should people be passive about their care, we actually have some empirical data based on a bunch of questionnaire data that we've accumulated over the years about passivity. These are passive patients. They have a high provider dependence score, and you can see that 40% of passive patients will have an important decline in their functional status of 10 points or more in a 1-year period. So maybe passivity is hazardous to your health. Greater passivity, and this is just recently, this is a manuscript under revision right now, leads to, and poor management confidence leads to poor glycemic control, independent of race and ethnicity, and you can't see this slide, but control for the kitchen sink in terms of access to care, process of care, interpersonal care, and disease burden. Management mastery is still a predictor of glycemic control. So what's the evidence for shared or participatory decision-making? Participatory decision-making style we've shown, and there's I gave the conference organizers a big, long bibliography, positively associated with health outcomes, patient retention, and patient experience ratings, and it occurs less frequently, that is, doctors don't involve patients in care without intervention. Now, some patients participate more effectively in treatment decisions than others. Younger people do, women do, and I have some data to follow up on that, and obviously more active people with more active orientation to their healthcare do. In terms of gender and patienthood, the most common, this is from audio tape data, the most common number of questions asked by men in a 15-minute office visit is 0.
Like asking for directions.
Yeah, exactly. The mean number of questions asked by women is 6. Women respond more, in addition, when you try to involve them in care and you develop interventions to involve them in care. Women respond, men tend not to. And I'll come back to the need for maybe remedial gender work on participatory decision-making style in a second. So training people to involve care, is it new? Well, my husband, when he should have been paying attention to something else in synagogue, actually came upon this algorithm in Leviticus. So the idea here is, and the slides are obviously available, all of this information leads you to, if you can actually graph this information into a treatment algorithm. It turns out that with certain kinds of symptoms, that's what you diagnose, leprosy, and then you observe them, and if not, you quarantine them, and if the lesion becomes stable, you quarantine, et cetera, et cetera. So we've been about disclosing information to patients in treatment algorithms for a long time. So sort of building, not on that evidence exactly, but building on that notion, we actually developed what we called coach care, and using personalized information in the patient's medical record and an algorithm that maps treatment decisions, we actually met with patients before an office visit, coached them to be more effective during the visit, and followed them up with phone calls. And more recently, we've actually implemented that with volunteers from community-based clinics and matched for, not gender, because we couldn't find enough male coaches that were really good at it, but matched for race and ethnicity, and trained coaches to support people during those visits, and actually found that compared to controls, we have very good documented evidence of reduction in biomarkers and also reduction in symptoms and improvements in function. This is the most recent data we have. This is also under revision. The intervention actually still decreases hemoglobin A1C values in poor and minority communities after 1-year follow-up. So in summary, with coaching, patients can participate effectively in treatment decisions. It improves patients' outcomes, and contrary to expectation, it really doesn't lengthen office visits. So what should we be doing with patients? Well, building on that and all the expertise and experience in this committee, in this enterprise here in our conference, we should also be involving patients in care in a much more systematic way. The details of that are in the first slide. Plus, we should also be teaching patients how to obtain, protect, and use personal health information, how to understand and navigate the health care system effectively and efficiently. And by the way, choosing wisely and other initiatives like that are going to make this even more important. How to teach physicians how to talk patients out of things, make sure they understand things don't need to be done. How to protect personal safety in hospitals. And I think Jonathan's example was excellent, but we have a far way to go. Even things like if you see the rails are down on your bed, either you or your family member need to pull them up. I mean, basic stuff to keep people safe in hospitals. And finally, where do we go next? Well, in the very voluminous briefing document that you have, there's a piece by Sherrie and myself that describes the notion of centers for planned patienthood. We really need to take this on as a national policy. There's right now, after 22 years of being at this, apparently longer than that, it's time to kind of make that a national initiative, that we need to teach people about patienthood. We may need to begin in childhood. I mean, some evidence suggests that we learn these notions of patienthood very early on. We can use, technology to advance the sort of whole principle. We don't need to have actual centers. They could be virtual centers, and we need to target, I keep doing that wrong, we need to target specific groups of patients that may be more in need of help, additional help, more basic remedial help to participate effectively, like men, the elderly, and people with kind of an additional disease burden that we call the potential for benefit. Maybe we should be offering degrees in effective patienthood. So if you get a degree from our University of Planned Patienthood, you may get some benefits on your premiums. You may get additional things that were down to you because you've actually done the work of trying to be more involved in your care. Thank you very much.